to give a cool little presentation for us. All right, so without further ado, take it away.
It seems so far away, but that's okay.
Actually, I almost said it.
Oh, no, you're good. Okay. So my name is Dr. Cheryl Pendergrass, and I am a principal associate professor of medicine at the U of A. I currently work at Banner University in Phoenix, both as a hospitalist and the night medical director. I also am medical director for AmeriCare Hospice here in the Valley. So, when I was asked to come and talk to you all, I was a little overwhelmed. Talking to a group of young students who are just starting their journey to becoming physicians or getting into healthcare of any kind. What do you say to them? What do you want to hear? What can actually be helpful to you all at this point? And that's hard because you're going to get lots of advice. There's going to be advice coming from every person you talk to, and some will be helpful, some won't. But it may seem overwhelming to you all at some point, all the advice and things you should do. Ultimately, I reflected on my career, which has been a number of years now, and ultimately I came to this. The most important thing that will make you stand out in a sea of applicants. Everyone's application has these big resumes. Everyone's gonna have good grades and good test scores and lots of jobs, research. There's going to be a lot, but how is yours going to be any different than someone else's? What it comes down to is your why. Why are you doing this? What is your passion for this job? Ultimately, you have to find that, because if you can find that, it will make you stand out. And one of the things that will also help you do is follow your own path. A path that you have is going to be different than anyone else's. It should be. Your path shouldn't be the same as your path. If it is, and you're looking at them going, oh, well, they're doing this, I should do that. You shouldn't do that. You need to follow your path. What's going to make it best for you, and find your passion for it. So Ram Dass says, it isn't true that everyone should follow one path. Listen to your own truth. And I know that sounds crazy and it's cliche and everybody's like, oh, everybody says that, but it's so true. So one of the things I decided to talk to you about is what my path was. My path wasn't like everyone else's, and so I figured that would be a good place to start. So initially, my why. Why did I decide to do this? When I grew up in a poor family, my dad was a cop, and we had all kinds of issues, of course. But one of the things that I realized is that my family was treated differently when the family had medical problems, they were in the hospital, different things like that. They were treated differently, and it made it very difficult. And what I didn't understand at that time was that I was right in the middle of a disparity in healthcare. Disparities in healthcare can be through so many different things. These are just a few things that present, and you have to, through your career, you have to be aware of these things, you have to acknowledge these things, because most people go through these and they don't even realize it. But it's super important because you want to take care of people. So one of the things that we realized, or what I realized when I was growing up, it was very hard to navigate, and it was really a nightmare for my family in that respect. Thankfully, we had a family practitioner who, his name was Dr. Boaz, and he was friends with my parents, and he was a very kind individual, and he would come to our house. When we were sick with strep throat, he'd come and give us a penicillin shot. When we needed immunization, he'd come to our house to give our immunizations. My parents' medications, he would bring them samples so they wouldn't have to pay for them, because he knew they wouldn't get them because they couldn't afford them. He let my parents work for him. My dad grew up as a ranch hand, and so so he helped Dr. Boaz take care of his horses. My mom cooked for them. We gave them produce from gardens, eggs from chickens, all that kind of stuff. And he let my parents do that for our entire life. I was the youngest of 4 girls, and I was the only one that wasn't into sports and horseback riding and all that stuff. I was into school, and he knew it, so I asked lots of questions, and I got good grades, and so he kind of became a mentor to me. He let me go to his office, and I went with him to home visits, out to the reservation. He did a lot of work with people who would otherwise not get medical care. He was really encouraging me to go into medicine. He was like, you could do this, you could make a difference, but it didn't seem like something I could do at the time. I mean, look where I was coming from, and I didn't think it was possible, but he was always there for me. And when I graduated from high school as valedictorian, and went to school down at the U of A, and I started my college education as a music major, because I thought, I'd be a teacher. I can be a teacher. That's something I could do. And I found out pretty quickly that music was something I loved, but I didn't want to do it for my life. And being a teacher was absolutely something I would never want to do. After a couple of sessions, that was it. Now, I changed, or I talked to Dr. Boaz, and we were talking about it. He's like, this should be assigned to you. You should go into medicine. This is something you should do. You can do this. And I still was like, I don't think I can do this. But I could be a nurse. I could do that. That's something I could do. And so I changed from music, and I just, actually kept my minor in music performance and everything though. And so I changed to nursing. And after one semester, and going to some shadowing events and watching physician-nurse interactions, I realized I didn't want to be the one being told what to do. I wanted to be the one looking at finding out what was going on. I wanted to, touch these patients, figure out what was going on, and then and really be that front person. I wanted to be the doctor, not the nurse. So I changed yet again to biochemistry. And Dr. Boaz was super happy about this, and he was, finally, you did this. You did what you were supposed to do. And I met my people. I mean, friends that I've had for life, and some of my med school friends, they were in those classes, and it was a great time. And Dr. Boaz and I had a conversation about going into med school, and he was like, I'll be there, I'll support you, I'll help you, guide you, so that way you can do this. And he knew I was afraid to do it. And so he just always pushed me to be mindful of why I was doing this. He knew that I wanted to be a voice for people who didn't have one. He knew that I wanted to be a voice for my family, for friends, for people who didn't feel like they had a voice in medicine. And he was like, hold on to that, and we'll get you through this. Unfortunately, that conversation was the last conversation I ever had with him. He was killed in a car accident, and at that moment, it was life-changing for me, because I knew at that moment that was what I needed to do. I needed to be that voice for all of the reasons that he said, but then also for him as well, because he was truly epitome of what I wanted to be as a physician. And so that is where it started for me. Now, getting into medical school, a whole nother thing. That could be a whole conversation all on its own. Getting into medical school, there's, again, so much advice. People are going to tell you lots of things. And again, I think it's about developing your passion, developing who you are, what makes you different than the person you're next to or who interviewed before you. And, I I didn't really know what healthcare really was all about. I kind of knew why I wanted to do it, but I didn't have a lot of experience other than the stuff I did in high school with Dr. Boaz. And so I did a lot of shadowing and volunteering, and I worked, in these different things, and I went to lectures, and sadly, when I went to interview for medical school, all it really did was I was more confused than ever. It was just everywhere. But I kept going back to why. I just kept going back to why I was doing this. And it was interesting because, and I digress a little in that, a funny story for my medical school interviews was that I was, a month before my first interview, I was playing intramural flag football. And I fell, broke my arm, and ended up with a cast, all that, and the cast would not, my suit jacket wouldn't fit over my cast. So kind of was like, stressed me out a little, but okay, I just wear the shirt, the skirt, the shoes, all that stuff, okay, I'm fine. So 2 weeks later, I was jumping on a trampoline with a broken arm, yes, in the middle of the night with no lights. Not the smartest thing to do. I ended up getting bounced off of the trampoline, and I couldn't see the ground, so I landed straight-legged on the ground, and I broke my leg. So here I am with a left arm fracture, a right leg fracture. I couldn't wear my shoes that I was going to wear with, when they were a little bit of a heel. So I had, cast up to my knee, and I had this walking Velcro shoe on. It was beautiful, and so I changed to slacks or the white shirt. It was kind of stressed me out because I didn't have the money to get new stuff. I just did with what I had. So when I went to my interview, or the different interviews, every single interview that I went in, I walked in, and the first thing that happened is the interviewers would laugh. And I got laughed, because nervous, but again, they were laughing, we were laughing, so we'd sit down, we'd have this conversation, and it was great, honestly, because it was a way to relax, and then I could kind of focus and realize that I could really talk about, again, why I was there, and it just kind of broke the ice. And my whole point of just saying that, one, is because it's absolutely ridiculous that happened, but find that thing when you go into your interviews that will help you relax, that will help you focus. You can't go in totally nervous. You don't have time to relax usually. And I don't recommend breaking limbs to go in, but you got to find something to help yourself relax to go in. Otherwise, you waste your time relaxing, trying to get focused, and then you're done. So anyway, so that was my crazy story about my interviewing, getting into medical school. So now in medical school, again, so many different things that we could always talk about. In medical school, there's so many things, and when you all get into medical school, those that you want to go, we can have a whole other conversation of what things you should do, things you shouldn't do, because there are a lot. So just briefly, the things that my favorite, this is going to be nuts, but favorite things, the medical school library. Our entire class, we all studied in the exact same cubicle for 4 years. Nobody moved. You were in the same cubicle, and it wasn't assigned, we just did that. And it was funny because we'd spend hours, multiple nights, everything, but in our cubicle. If you wanted to leave a note for somebody, you could leave it in their cubicle, knowing full well that's where they were going to study. And all the different years had different places and floors in the library and everything, so it was actually kind of funny. But it was great because it gave you some security and something, that was familiar, so it was really more of a safety thing. So I worked in the homeless camps down in Phoenix, downtown, and that was a great experience for me, even during medical school, because again, it kept me focused on what I wanted to do. This is kind of the evolution of my job, is that, again, this voice for these people who are either brushed aside or don't have access. And I met some amazing people, and it was definitely an experience. Now, class-wise in medical school, anatomy lab is by far the best class you will ever have. It is the one place where you will start your medicine career. It is where you start to have actual contact with you you have a real body. You're looking inside of it. You have this connection with this person who donated their body so that you can learn. It is really an emotional time, honestly, too, because you realize this is a real person, and you spend your whole year with this person, and it's not just a body, it's a person. And you will spend more hours in that lab than you will in anything else, and it's amazing. And you will learn more there than you will anywhere. Now, medical school, when I went, we had just these metal trays, and there were 6 people around it, and that's it. It was just this metal tray. That was it. And, and then obviously you can see the wash stations behind and everything, and so this was what we did, and this is what it looked like. And now, what's interesting, and we did all of our dissection from this paper. This paper gave you little steps. You go here, you do this, look for that, look for this, tag that. It was just a step-by-step approach through the entire body of dissection. But it was all on paper. Nowadays, it's very different. It's pretty cool what the anatomy labs have now. Now this is the U of A. It's all fancy, and these beautiful tables and chairs and these surgical lights above. It's crazy. It's crazy amazing. And these screens that they have are these plasma screens that have this, you can get real time. They can do like a dissection tutorial for you. They can show you x-rays of the area you're dissecting, MRIs, CAT scans, everything. So you can use this anatomy lab even better now. If I could go back and do one class, that would be it, because it's even more amazing now than it was before. So the way anatomy ends, though, is your last lab. You do a final wrapping of the body, and you prepare this person to be cremated, and their remains be sent back to their family. And it's a ceremony. It's a lot of reverence and a lot of appreciation. And we all wrote letters, anonymous, of course, to the families of these people who donated their bodies to us, because it was by far the most impactful class that we had, not just for learning, but in many ways. So that is a class that I hope, if you choose to go to medical school, really look forward to that one and delve everything into it, because you can learn so much. So. Now, my choice for residency was, and again, just like many other things, this is another long conversation we could have. How do you choose what kind of medicine you want to go into? Medicine, there's so many different things. Do you want to do family practice? Do you want to do pediatrics? Do you want to do surgery, internal medicine? And internal medicine and surgery, underneath those, you have tons of things. There's general surgery, there's cardiothoracic surgery, there's, hepatobiliary surgery, there's all these things. Internal medicine has everything: endocrinology, rheumatology, pulmonology, critical care, everything under the internal medicine umbrella. So because I didn't really know for sure what I wanted to do at the time, after doing my routines, I knew I didn't want to do surgery or family practice or pediatrics, and so I chose internal medicine because there were lots of things I was interested there, and went to residency here. It was Good Sam at the time. It's now called Banner University in Phoenix, and did my residency there. And during residency, you find, again, a lot of things that you want to do, and one of the things I found out very quickly is I did not like outpatient medicine. Working in the clinic was boring, and it was something I absolutely swore I would never do. But in internal medicine, what on earth are you going to do? Because most of internal medicine is, internal medicine primary care doctors. Thankfully, during my time in residency, something happened in the medical community, and it was called the hospitalist. The hospitalist, when I was in medical school and started residency, didn't exist. There was no such thing. While I was in residency, there was this new thing on the East Coast called the hospitalist. And the year before I finished, one of the residents that finished the year before me went to the Good Sam administration and said, hey, you know what, let's start this pilot program for this cool thing called the hospitalist. I want to show you how this could work. And he was such an intelligent, and he could sell you anything. And so he sold it. They took it and they allowed him to start this pilot program with just him and one other guy that was finished with him, this hospitalist movement. Before then, all the patients in the hospitals were taken care of by primary care doctors. Primary care doctors would come in before or after clinic, specialists before and after clinic, and things were slow in the hospital. And when this hospitalist thing started, the primary care doctors were furious. They were like, oh, these people are going to come in and start taking care of our patients. They don't know our patients. Oh, this is horrible. It'll never work. They didn't realize this was the future, though. And within a year, they realized that this truly was going to be the future of medicine in hospitals because it improved their life. They didn't have to come into the hospital after clinic or before clinic. They didn't have to come in on the weekend. They didn't get called in the middle of the night for their hospital patients. Insurance companies loved it because it saved them money. Because patients weren't staying in the hospital as long. Hospitals loved it because there was lots of turnover. There were so many things. Patients loved it because their doctors were always there. They could call. Their doctors were always available. And so patient satisfaction went up as well. So there were so many things about the hospitalist movement that were so important to in hospital medicine. So when I finished, they asked if I wanted to join this movement, and so because it sounded like the coolest thing ever to stay in the hospital, work in the hospital, I decided to stay, and so I became the first female hospitalist in Good Sam, in Banner University, and I've been there ever since. Now, one of the primary care doctors who was actually really involved with it and really wanted this hospital movement, one of the things that he talked about was what could happen to physicians who were always working in the hospital. If they were always taking care of the sickest of the sick, they were always dealing with critically ill patients, and it was a difficult transition because it wasn't something people knew what was going to happen. So it was stressful, and there was a lot of burnout, and people were very tired. And so one of the things he encouraged many of us to do, that when we started, was to find something else to balance us out. So in 2005, after being a hospitalist for 5 years, because I started in year 2000. In 2005, I started working for a small little hospice in the East Valley, and because the hospital, you were doing everything. You're doing everything to patients. You're constantly, more tests, more studies, more this, more that, even until to the very bitter end. Whereas in hospice, we can take that step back. We can give them that voice. We can give them security. We can give them comfort. We can give them dignity and not have to go through really the torture of what we do sometimes in the hospital. So I worked for, and a couple years later I became their medical director, and I have continued to work with hospice forever. I call it the dichotomy of medicine, because in the hospital you do everything to the patients, whereas in hospice you do everything for the patients. So then over time, my job from where I started in 2000 is very different than it is now. Medicine is ever changing. There are things that are always happening, whether it's innovation, events. There are things that will always change the things that happen. And working your way through medicine is like this maze. You're going to go down one place. You're going to turn around, hit a dead end. You're going to have to turn around, go back. Did you go down that path before? It's exhausting. It's frustrating. It's tiring. But I keep going back to why you're doing it. If you don't have a reason why you're doing it, you won't survive the frustration and the exhaustion of it. It's like riding the wave. You have to ride the wave, whether it's a hurricane and you're being tossed and beaten up, or the calm days where it's beautiful and you can do it forever. You just have to hold on to your why, and your why will get you through the worst of your hurricanes. My worst hurricane in my entire career was COVID. COVID was something that changed everything, and yet again, another conversation we could have. It changed the landscape of medicine. It changed how we treat people. It changed, the whole environment in the hospitals. It changed us as individuals. Banner University was the COVID hospital in the Valley, and so we got the sickest of the sick. We had 10, 20, 30 patients dying every day. These were things that change you. And the thing that I kept holding on to is that I was a voice for these people. They were alone in the hospital. Families couldn't come in. We were the only voice that these people had. And so really it suited me well because it was why I went into medicine. And as painful as it was, and it changed me for sure, it was an amazing time as well because I felt like I was doing something at least for these people. But again, it's why, my why is how I got through it. And many people didn't. Many of my colleagues quit. Many of my colleagues just couldn't do it anymore. And it was definitely a time that changed all of us. Helen Keller is obviously, a bend in the road is not the end of the road unless you fail to make the turn. The whole point of that is that you have to keep going. You have to be resilient. You can't give up. Now, and lastly, my advice. Everybody always asks, what kind of advice can you give me right now? I can't give you one thing. I can tell you, you've got to find, again, that passion. I do interviews for medical students for the U of A. I do interviews for the residency program at Banner University. So I see these people come into these interviews, and I've been there. And so I see them come in and with these big resumes, but they have no idea why they're there. And they can't tell me anything except for they did this and this and this and this and this and this. That's not what's going to come through in your interview. Know why you're doing this. Know what your purpose is in medicine, and have a conviction. When you go in your interviews, that will come through, and you will succeed if you have that. And so, of course, I have to finish it, of course, with Steve Jobs. Your work is going to fill a large part of your life. The only way to be truly satisfied is to do what you believe is great work. And the only way to do great work is to love what you do. If you haven't found it yet, keep looking. Don't settle. As with all matters of the heart, you'll know when you find it. Thank you. Right. Question. There's lots of things you can ask. You can ask anything.
I'll start it off with my favorite question. What does a typical work day, evening look like for you?
Right. Well, I am one of the nocturnists, so I'm the night medical director, so I work only nights. I've only worked nights for my entire career. I worked for 8 months. I worked during the day, and it's because we didn't have nocturnists yet, or enough, because we didn't really know what we were going to do with the night thing yet. So for 8 months, I worked during the day. The rest of my career, I worked as a nocturnist. The day job, obviously many of my colleagues work during the day. And the day job, they're 12-hour shifts. They're 12-hour shifts usually, and some hospitals do them 8, but they're 8 or 12-hour shifts. And the great thing about being a hospitalist is that you don't take call. So you go to the hospital, you do work. It's a little bit like emergency medicine in some ways, but you don't have to deal with people coming in. Oh, my finger hurts. You're taking care of truly sick people. You're not taking care of all the stuff in the ER, because the ER gets lots of garbage. We know it. It's the truth. When you're in the hospital, you don't get that. So 8 to 12 hours of, they usually work 7 days in a row, and then you do 7 days off, 7 days on, 7 days off. And you can do that. And you can run it. The great thing about hospital medicine is that it's very, it's flexible. You can, you can work all your days at the beginning of the month and have the entire second half of the month off. You can do things that you couldn't do in primary care or in some fields. So typical days are very long, and they're busy, and they're not slow ever. At night, there's no sleeping. We run all the codes in the hospital. We deal with all the patients that are, either crashing or need to be intubated or need to be, transferred to, the surgery or, anything. There's so many things that we have to do. But it's great because then when you go, you do get to leave that there. So, yeah. Other questions?
So you also work with hospice. How does that differ from your work in hospitals? What kind of cultural shifts do you see
It's very different. And again, that's why I do it. It keeps me very balanced because again, in the hospital we're dealing with patients usually who want everything done, mostly to the bitter end. And honestly, many of my colleagues use me to go and talk to these families about, end of life palliative care. Do we really want to keep going down that road? Is that really something that's going to be of benefit? Is there going to be a quality of life after that? Many physicians are uncomfortable having those conversations. So for me, it truly helps the person as a whole because you can have a quality of end of life. You don't have to battle to the bitter end. It really is okay. You can help people accept that at that point. And so it's really, again, like I said, it's the dichotomy of medicine. It's completely opposite of what you're doing in the hospital versus during hospice. But ultimately, the good thing is that I've been able to try to bring some of the hospice stuff into the hospital, again, just to make it less taboo, make people understand that it really is okay to stop sometimes. And it's becoming more prominent. It used to be kind of a taboo. You couldn't talk about it because, you're dying, it's against the law or something, I don't know. But now, the great thing is that it's a new thing. We actually are allowed to talk about it. The hospital has initiatives now that we started about 10 years ago that we have to ask what someone's code status is. Do they want to be intubated? Do they want cardio? Do they want to be resuscitated? Chest compressions, shocking, all of that stuff. And we actually have it's a check thing now that every physician has to do in their admissions to every patient now. So that's a huge shift in just the last 10 years. So it's a great thing. But long-winded answer, but yes, it's very different. Other questions? Yes.
You talked about how COVID was really affecting a lot of physicians. How would you describe how COVID affected a lot of physicians in such a rough situation?
Oh, that's a loaded question. COVID was difficult in so many ways for us because we weren't really allowed to show emotion at the time. We had to be, the front, and we had to deal with not having enough PPE, and we had to deal with, reusing things, and we had to deal with all of this stuff, and it was a constant battle, and then we had families yelling at us because we wouldn't let them see their families, and it wasn't our choice. It was just we were the person that was the front. So we got the hospital constantly yelling at us. We got the nurses yelling at us. We got the patients and the families, and then people dying. And it was like being beaten every single day. And we weren't allowed to talk about it. There was no discussions. There was no when someone would break down and have like crying, and because there was plenty. It was amazing. They were kind of. The nursing supervisors in the hospital were informed to whisk these people off to a quiet little room, let them get themselves together and get back at it. There was nothing. It wasn't until this year that we actually started having discussions and really, regrouping with those of us that were in the COVID horrible time because, we had a couple doctors commit suicide during the time. We had doctors die during that time. When you have your colleagues, dying of COVID and, committing suicide, come on. We needed help, and they weren't giving it to us. And so, again, in intensivists over at Scottsdale Shea, Dr. Rashke and myself started an initiative to, just this early, it is in 2023, to help physicians, to talk, to sit down in little groups. Not take more time, not psychotherapy, but just to talk about what we went through, because we weren't allowed to talk about it. We weren't allowed to talk to the press. We were told not to talk to the press. We were told not to write articles. We were told not to talk to anyone about anything. And So yes, the mental health part of it was terrible. It was terrible. And we're just now starting to truly heal from it. And we can't even begin to impart to everyone what it was like during that time. And so we are just starting, literally the world is starting to already, they've moved on. People who have worked in it are just starting.
Yeah, I guess on the topic of end-of-life care, how do you approach a patient and tell them, well, there's a high likelihood you're gonna die, right? How do you get over like the kind of like the deep feeling in your heart when you have to say something like that? How do you get over it?
Yeah. Well, hopefully you never really truly get over it. Hopefully you truly always feel some emotion for these patients. But you do over time, there is a little bit of, when you rub your hands forever, you get a little bit callous, and you do get that. Every physician does, of course. But you go into those conversations every single time with the respect of that person, and you tell them, and you're truthful with them. You're truthful with them, and you lay it all out, and you tell them the different options that they have and what the likelihoods of those things are, but that you can be there to help them, to be at home with their loved ones without pain and not alone. And if they don't have family, there's plenty of places that we have for hospice that they have someone with them 24 hours a day. They don't have to keep fighting. And so it's really about being honest and being upfront and showing empathy with these people, though, and it works miracles, really. What was the reason, or how did they do it? Okay, so they sent out an email saying, don't talk to anyone, don't talk to your press, don't talk to people outside of the hospital, be mindful of what you tell your families. And initially it was, and really truly initially it was because nobody really knew what was going on. That was the first part of it. Nobody really knew how bad this was going to get. Nobody had even an inkling of, really what these hospitals were going to deal with. I mean, hospitals weren't prepared, the physicians weren't prepared, no one, our country wasn't prepared. And so they didn't want us talking about it to spread fear. We didn't want to spread panic. We didn't want people starting to hoard things and do things. So they didn't want us to talk. Now that evolved, though, over time, where they didn't want us talking to the press as the hospital got fuller and fuller. Our hospital was 100% COVID. We had no patients that weren't COVID patients. Every single floor. And if you've seen that Banner University Hospital, we have a new tower that's 17 floors. We have an old tower that's 12. Every single floor was COVID. Not one wasn't. I even get chills thinking about it because it's just mind-boggling how many there were. They didn't want us talking because we couldn't let people in. Because if we let people in, more people are going to get sick, and more people are going to get sick. So they didn't want us telling people how bad it was because, they would want to come and see their loved ones. They would want to come and protest, and they would want to come and do all these things. So they said it was for our protection, the hospital's protection, the patient's protection. And again, it evolved further, where it became more of a mechanism of hiding things too. There was hiding, and it was hiding because they had failed. Much of our healthcare system had failed the patients, had failed the patients and the physicians and the nurses, and they didn't want people knowing this. We all know it now, of course, but at the time, and they made it very clear if you said anything that you could be dismissed, just like that, and that, with lots of threats. And so, honestly, we were dealing with so much other garbage that we weren't going to say anything and put that at risk as well. We just didn't even deal with it. We were dealing with day-to-day things, and it was just, we've saved all those emails, those of us that now we're talking about all these things, and it's really the evolution of that, those threats. It was crazy. It was absolutely crazy. And so there's not a clear answer of necessarily how or why it evolved through COVID. So if that makes any sense. Other question? Well, here. Yeah.
Let's get back to the really in-depth, very, very serious topic.
Yeah.
What's your favorite part, I'd say, about, I guess it's both being a hospitalist and also hospice, if you have a least favorite for either one.
Yeah. Well, hospice, obviously, I have to start there because I get so much satisfaction out of working in hospice. I mean, I have a different view of death and dying now than I ever did. It has evolved over time, of course, and so I get so emotional, and it just gives me a great sense of satisfaction when I can help someone accept where they're at and help them die not alone and with dignity and without pain and comfortable. It's truly a blessing, and it's a very different experience than what I do in the hospital, which is my least favorite thing, of course. In the hospital, when we are doing, when we're intubating and we're putting more lines and we're doing more procedures and and it's a 95-year-old person who's got a brain mass, who's bleeding, and they're not going to survive, but the family won't stop. So unfortunately, we have to keep going until that person dies, and they will eventually, despite everything we do. And it's the worst part of my job, because you know that you should have stopped, but you don't have a choice. So that's my worst.
I apologize if I missed this because it came a little bit late, but if you were to choose a specialty, because you're just a general internist, right?
Yep.
What would you choose? What maybe would be the last one that you would choose?
So I hear you. You want to know what I would choose if I did a specialty? Okay, yeah, easy for me, because with all the years, the one thing that I would have done is I would have done pulmonary critical care. Absolutely. I did so much of it already as a hospitalist because, when hospitalists first started, there were no intensivists in the hospital. We were the ones that did all the lines and the intubations and all the procedures and all the codes. We did all of that. And, had I been trained, and in fellowship in pulmonary critical care, then I felt like maybe I could have done even more. It got to the point where I wasn't going to go back to school, though. I was done with school, and I had been out for a number of years. But yeah, for sure, if I could go back, maybe. I don't know. It was one thing I truly, really love. Thankfully, as a hospitalist, I get to do some of it. But yeah, that's the one thing I would do for sure. So, yeah, and no outpatient medicine at all. No clinic, ever. So, anyway. Yes.
Not to kind of race back to the COVID,
No worries.
I was curious about how you went about electing physicians to participate in the initiative that you kind of mentioned that you started in 2023, because I can only imagine with how restricted you guys were, like at the time when you was communicating to each other, expressing how you felt at that time, like how you went about kind of reaching out to other physicians and like reintroducing, reopening that like line of discussion.
It was way easier than you think, and way easier because everybody bursting. Everybody wanted to let out. It was there. No matter, even the most stoic of physicians that were out there in the world, even some of those surgeons that were never there, everyone was bursting at the seams to talk about what they had been through. I mean, and the more they talk about it, the more they heal. And so you would be amazed with how easy it was. And all we had to do was invite them. And the hospital, of course, it had changed, and there was permission. Everything was out in the open, of course. And so people wanted to talk. People wanted to, people to understand what I wanted to talk to somebody else, so they knew that I understood what they were going through. And so we could be like, oh my gosh, you remember when? And oh my gosh, it was the worst. And just to understand, kind of get some validation that you went through the worst time of your life, and you were okay. But to continue to heal from it, we needed each other, and it was crazy. Yeah. So to add to the COVID thing, the one thing that many of us had to deal with was that
almost all of us ended up getting COVID, of course. And like I said, some of our physicians at the hospital did die. And to take care of your own colleagues was a whole nother thing. I mean, we don't take care of our own family because, you know, that's not allowed. You could be somebody else in your group could do it, but we can take care of our own colleagues, and that in and itself was difficult. And you know, most of us that worked in the hospital ended up in the hospital for a period of time. And, you know, in that fear, when you're in the hospital, you know what's going on, and you know how many people are dying. And when you're lying there, and you think you might die from this horrible disease, it was definitely a time that we did not deal with it well at the time. And so this last year has been so important for the healing from that time, and that's why I use it as an analogy, and when I talk about it being a hurricane, because it truly was a hurricane in our time. Anything else? Now, a parent has my contact information, of course, and if there are ever questions, or you want to talk about anything else or something specific, you can always, you all can reach out to me individually. Honestly, I don't mind at all. Parent can reach out to me. Although I'm so far removed from where you all are, I still love to try to empower and help you all, find that passion, because it really is an amazing job. And it's an amazing life, and I wouldn't change any of it. Great.
Thank you very much. That was wonderful. Thank you very much for coming. It's really great to see you all out here.